Dear Chairman, thank you for a kind presentation. Colleagues and ladies and gentlemen, renal cell carcinoma, it's a disease that accounts about 3% of all malignant tumors of the adult population. In the oncourology, given type of tumor ranks in third after the prostate and bladder cancer. Here we can see the morbidity and mortality rates of the American continent and European continent. According to the recent European guidelines of neurology, there are options for the treatment of this disease based basically on the aggressiveness of the tumor, which depends on the histological subtype of the tumor and the grade of differentiation of the tumor. And the most common type is a clear renal cell carcinoma, and less common are the papillary and chromophobe subtypes. Recently, computed tomography is considered to be the golden standard in the diagnostics of RFSC. However, advanced MRI diagnostics such as DWI imaging are being explored in the assessment of the renal masses. Some authors reported pretty good results in the diagnostic between the benign renal cyst, malignant renal cyst, renal cell carcinoma, and benign renal tumors. Critical analysis of the literature based on different sources, pretty inhomogeneous, basically due to the different B-values used by the authors, lack of the data on a papillary and chromophobia subtype, and the result, different sensitivity and specificity in the different scientific trials. The objective of our survey was to assess the value of the DWI and ADC in differential diagnostics of the malignant renal lesions. We observed 69 persons in general, 54 adults with a pathomorphologically confirmed renal cell carcinoma, and this group was split into 4 subgroups. First subgroup, it's 25 patients with a solid subtype of the clear renal cell carcinoma of different formal grades. 8 patients with a cystic form of the clear renal cell carcinoma, 12 patients with a papillary renal cell carcinoma, and 9 patients with a chromophobe renal cell carcinoma. And also we explored 15 healthy volunteers. In all patients diagnosed with RCC, a consecutive partial or radical nephrectomy was performed with subsequent pathological verification diagnosis. Anti-tumor therapy were not performed, and biopsy also was not performed prior to MRI. And exclusion criteria were patients with renal insufficiency, multifocal RCC, Bosniak cyst of first, second, and third classes, metal object of the body, and the low quality of the image. Here we can see the characteristic of the groups of the patient, including age and sex. We can see that age parameter is pretty comparable in all groups. And in all patients and healthy volunteers, the MRI was performed, which include DWI, followed by ADC measurement on 1.5 Tesla scanner and height using the 8-channel phased array body coil. We use standard general electric MRI protocol, which used T1 and T2 weighted images, both 2D and 3D, and also actual DWI that was conducted before the contrast media administration using single-shot echoplanar imaging sequence, and B-values were 0 and 800. Func tool was used for the ADC map generation. Region of interest was placed within a portion of area of a lesion where the minimum ADC value on the ADC map was registered according by the color with visual inspection. And the average of 2 or 3 measurements per lesion were performed depending on the lesion size. The results of our examination was that tumors had predominantly irregular shape on MRI images with irregular and indistinct outlines. You can see the tumor diameter was larger than 7 centimeters only in a group with a cystic clear renal cell carcinoma. The MRI characteristic of the tumor on conventional MRI sequences were different in different histological subtypes, mainly differentiated by the T2 sequence. In a solid clear renal cell carcinoma, intermediate to high signal on T2, cystic the same picture, papillary low signal intensity on T2, and chromophobe, in the case of chromophobe renal cell carcinoma, was in 62% low signal, and intermediate period and the high signal in 38% of the patient. Here we can see the example of the abdominal MRI 65-year-old man with a pathologically proven clear renal cell carcinoma Fuhrmann grade 2, and we can see on T2 increased hyperintensity of the tumor, also restriction of the diffusivity on the DWI image and the ADC map. The second example is 62-year woman with a pathological proven clear renal cell carcinoma from grade 3 with increased intensivity on T2 image and restricted diffusion on the DWI and ADC map measured by the ROI. And the third example is a pathologically proven chromophobe renal cell carcinoma. We can see the conventional images and the restriction of the diffusivity. In this case, we had the hyperintense region on the T2 image. The result, in the result of performed analysis, it was found that average ADC value of the malignant tumor was significantly different between the different histological subtypes of the RCC. Here we can see the box plot that shows the difference between the solid kind of the tumors and the cystic clear renal cell carcinoma, and difference between the different Fuhrmann grades of renal cell carcinoma. But the statistical analysis showed that statistically reliable result was seen only between the first and the fourth grades in the case of solid clear renal cell carcinoma in our groups. Our study has some limitations, like a relatively small amount of the patients. That's why the calculating of the specificity and sensitivity of the method will be our future goal. So the results where we observed statistically significant difference in mean ADC values of solid tumors, of solid forms between them. The cystic form of clear renal cell carcinoma had significantly higher mean ADC value than solid forms. The method of diffusion-weighted imaging along with ADC measurement gives valuable information for the differential diagnostics of the malignant renal lesion, but have limitations in differentiating between the grades of the solid and cystic forms. Statistically reliable difference was observed only between the clear renal cell carcinoma, its solid subtype, first and fourth Fuhrmann grades. Thank you for your attention.
Thank you for this nice presentation. Is there any question from the audience? The question. Yeah.
Thank you for the question. The answer was, in fact, in the beginning of my presentation. The treatment options, including the active surveillance, in the case of renal cell carcinoma, depending on the aggressiveness of the tumor. And the Fuhrmann gradation correlates with the survival rates and the aggressiveness of the tumor. That's why it's very important to know what type of what grade of the tumor we have to perform the planning, surgical intervention, or active surveillance, including other factors, of course, clinical data.
Thank you. I have one more question. You probably retrospectively looked at the pathologic diagnosis and then compared it with your results. Did you have any patients with abscess formations as well in your group? Did you compare if there would be an overlap? Because you compared with healthy volunteer and there was really a difference, but there might be overlap with chronic abscess formation?
Thank you for your question. We had different lesions, including the abscesses, including the benign tumors like angiomyolipoma, like oncocytoma, but the amount of them was reliably too small to present the data on this conference, but it will be, of course, in the future when the amount of patients will be. And as we saw from the box diagram, we had some overlap of the ADC values between the healthy volunteers of their normal renal parenchyma and the cystic form due to the mean ADC value. But visual inspection and application of the other conventional MRI sequences giving the possibility to differentiate between the normal parenchyma and the cystic lesion. So this is not a problem.
Thank you. If there are no further questions from the floor, we will proceed to the next talk.
Thank you.
It's